This is a presentation about an update regarding COVID-19 and the virus causing it. Everyone knows that things, whether related to the virus itself, method of transmission, the diagnosis of the infection, the treatment and vaccination are moving rapidly. And they are changing not month by month or even week by week. I can say every day there are some changes there. We are dealing with a disease with a unique situation. I can say that this is the first disease which attracts such volume of attention, concern and investment at all levels, at the universal level, in addition to the government levels, official levels, group and community levels, in addition to individual and family levels. I'll start by some idea about coronavirus. A lot think that we are dealing with one or two types of viruses here, but going back to the classification, coronavirus is a family of viruses which can attack both animals and human. It is family Coronavidia there, and there are four groups within this family. The first one is alpha coronavirus, the second one is beta coronavirus, the third one is delta coronavirus, and the fourth is gamma coronavirus. These attack both animals and humans, and there are a lot of subgroups and also strains of the viruses within each of these groups. The human coronavirus, which is the viruses, a group of viruses which attack human beings. There are 6 species of them. They were discovered or they were founded in 1960. 4 of them cause the common cold symptoms that all have at some stage of life. 2 of them are from the alpha coronavirus group, and 2 are from the beta coronavirus group. There are 2 other strains which are known to cause the 2 widely known epidemics. The one in 2002, 2003 in the south of China with the acute respiratory syndrome, which is the SARS. And this one is part or a member of the beta coronavirus of a lineage B. At that time, that was the origin of the infection, and it was not quite clear whether it was transmitted to human being through an intermediate host. The second epidemic with another coronavirus from the beta coronavirus group is the virus which caused the Middle East Respiratory Syndrome, MERS, which appeared in Saudi Arabia in 2012, and with this epidemic, the source was the camel, and it was a direct transmission to human being. Obviously, those are the 2 major epidemics caused by another coronavirus within the same group of the coronavirus family. We thought that mortality rate of both of them were much higher than our current COVID-19 epidemic, but when we look at the numbers, we see them much less than the number involved by our COVID-19. The overall number in the SARS epidemic was in the region of 7,000 to 8,000. of them, the mortality rate was 10%. While for the MERS epidemic, the total number was in the region of 2,500. Of them, the mortality was up to 37%. The full gene sequencing of our current virus, which is SARS-CoV-2, SARS-CoV-2, indicates that it is much closer to the virus causing the first epidemic, which is the SARS. And the virus causing it is called SARS-CoV-1. This relation is mainly in the fact that both act at the same receptor, which is the ACE2 receptor, and which is the receptor joined by the spike, by the S1 protein in the virus, and serve to enter the virus into the cell and replicate inside the cell. So both have this similarity, while the virus causing COVID-19 is a bit distant from the virus caused MERS epidemic. Now, of the details that we discovered, that coronavirus causing COVID-19, that is the SARS-CoV-2, is not one type. A study for classifying the types of the virus causing COVID-19 in China, using 103 patients from different areas, indicates that there are two types of this virus. And I will start, for the simplicity, describe it as CoV-2. So CoV-2 is two types rather than one. One is type L, which is the dominating virus with about 70% of the cases, and it dominates in the first city involved with the epidemic, which is Wuhan, and it was much less in areas, even in China, outside Wuhan. The second type is the type S, which accounts for 30% of the cases. These are more in the areas outside the epicenter in China, which is Wuhan. There is some belief that type L tends to be more aggressive than type S. It's not quite clear whether this can be substantiated by some clear evidence, but it sounds that the cases from Wuhan, they have the worst outcome and prognosis and severity of the disease. I don't have much statistics and idea about which type is spreading in the rest of the world, particularly Europe and America, as I couldn't find much statistics on that type. But it's not clear whether the differences in the two types can be reflected on the differences in the severity of the disease or in the prognosis of that disease in other areas than China. The routes of transmission. Everyone knows that the droplet, which appears during talking, coughing, or sneezing, is the source of transmission of the virus to other people. These droplets can travel up to 6 feet, less than 2 meters. And the overall estimate of the time for those droplets to linger in the air is less than 1 hour. Initially, it was estimated as to be between 15 and 30 minutes, and now the overall teaching is that it can stay in the air for up to 1 hour, except for one study which came in from the New England Journal of Medicine on the 16th of March. In this study, which was experimental, it wasn't conducted in real life, but it was in experimental environment. It was thought that the virus can linger in the air up to 3 hours. The second source of infection is the contaminated surfaces by those droplets. And initially we thought that this period of contamination can extend on those surfaces between 12 and 24 hours. But that study, which was the only study, by the way, there are no other study, the study published in the New England Journal of Medicine, indicate that the virus can stay longer on surfaces, and there are differences between those surfaces. So the longer staying is on plastic surfaces, which can extend up to 72 hours, followed by stainless steel surfaces, which can extend around 48 hours. The cardboards can keep the particles up to 24 hours, while copper can have it up to 4 hours. Again, these are data from one study, from one experiment. And the overall thinking is that the period of staying on surfaces after falling the droplets is around 24 hours. Now, the epidemiologic characteristics of the new virus, the CoV-2 virus, which caused COVID-19, are not related only to the differences in the duration of the virus contaminating surfaces. It is mainly related to the fact that this virus, CoV-2, can stay or can have a high concentration of viruses in the upper respiratory tract compared with other viruses of the same family, compared with the SARS and with the MERS viruses there. So this is the main difference which make this virus, first of all, more contagious, and secondly, can last long when a case happens. The second difference can be the differences of the duration of staying on surfaces compared with the other viruses. The third can be related to the fact that this virus has been isolated from blood and stool of patients affected, including following a full recovery of the symptoms. But the joint report of the WHO and China, there's a report which appears as an outcome of a work between the WHO and China, indicates that the clinical significance of the presence of the virus in the stool and the blood is not clear yet, and it is not significant. Now, acquiring the virus and the disease is through close contact, and close contact means a distance of less than 1.5 from the source, from the index case, over a period of more than 15 minutes, or having a group or having a communication in a closed place over a period of more than 2 hours, plus the contamination with blood or with other body fluids. Now, the data about what percentage of close contact end with attracting the disease is, in China, it is estimated that close contact can create 1 0.1-5% of infectivity or infection by contact. Data coming from cruise Australia indicate that this risk is around 2%. And there is some data from United States which make this risk is in the region of 0.45. But I doubt that this rate is still there after the expansion of the epidemic in different states of America. Now, before going through the diagnostic details of the virus and the disease, I would like just to stop at the clinical manifestations, and by now everyone knows that it is a spectrum of flu-like illness and symptoms to start with, including fever, which is almost in the majority of the cases, anything between 85 and 99% of them. They develop fever, usually high grade, at around 39. 2, the extreme malaise, exhaustion, lethargy, and tiredness. 3, the cough, which is usually dry cough, although there are about 27% of cases there is a sputum, so it's a productive cough. There is severe myalgia, anarthralgia, and a drop in the appetite. Now, later data indicates that diarrhea, in addition to vomiting, can complicate the picture even during the early stages, even in cases which are considered as mild, which account to around 80 to 81%. Now, in the 14% of the cases, the patient develop pneumonia, usually not severe enough to require any respiratory support or hemodynamic support, and is usually treated in a hospital environment with antibiotics, starting with intravenous antibiotics, oxygenation, and hydration. The 5% of the extreme spectrum of the manifestation are the one with severe features requiring admission to intensive care with mostly intubation and assisted ventilation and probably hemodynamic inotrope support. So this is the spectrum of manifestation we came across all over the world. Now, for the test, the lab test, the most commonly used and reliable test is the test of the swabs using PCR. So this is a test which can amplify the tiny particles of the virus even if they are present in scanty amount. The swabs are either from the nose or from the throat. And the nose is preferred as it's thought that the level of the virus concentration is higher. But these swabs from those two areas are helpful in the first week of the infection as the concentration of the virus, both in the nasopharynx and the oropharynx, declined significantly in the second week, in which case samples from the lower respiratory tract should be considered, including inducing sputum, the induction of sputum, and including getting samples through catheter. Now, we should know that this test is not perfect, like most of the tests. And there is about 10 to 15% of falsely negative, which means a test which is negative in the presence of all the clinical features of the disease. In this case, in case of a negative test, negative PCR test in the presence of significant features of COVID-19, then a bronchoscopy and a bronchial lavage to get the samples would be the alternative. There are around 41 type of this test, the PCR testing of the swabs there. And with them there are around 2 depend on serology, but not for antibody. The current one we use are probably having a duration of anything between 8 hours and probably 24 hours. Usually the result on the second day. But there are at least 4 trials which work on having the result within the first hour, which make huge difference in the checking, testing, and also in the control of the disease. The kit and the validity of the kits there and their usefulness is not universal. That's why the WHO accredited 7 laboratories for the development of those kits and also for the protocol used to test the swabs. 3 of them includes United States, Germany, and France. The other includes China, Japan, Thailand, and Hong Kong. The certain laboratories in those countries are the only qualified laboratories to produce, develop those kits, and their protocols are the one we use practically to test for the virus. The second type of test is the serology. Now, initially in the course of the disease in January or February, there was a thinking that serology wouldn't add much to the diagnosis of the disease and the detection of the virus for a variety of reasons. But this thought has been changed as much more evidence appear that serology can be helpful. Serology is testing the antibodies which the body produces in fighting the virus, both of the IgM type, which appear very early in this process of fighting and production of immunity, and the IgG, which appear later. And the IgM indicates the acute phase of infection or the recent infection, while the IgG raises the possibility of an exposure in the past at some stage. Now, the first evidence on a beneficial use of serological test in the diagnosis of the virus and the disease is that this serological test can increase the sensitivity of the diagnostic tools used in the diagnosis. Cases with a false negative swab test or PCR test were studied in a small study. The total number was limited, of about 58 patients with the typical features of COVID-19. And 93% of those cases with a negative PCR testing were tested positive for the IgM presence in the serum of the patient. The second beneficial use of serological test, the antibody test, is in the prognosis. So detecting the antibodies at a high level is a prognostic feature of a worse progress or a worse outcome. So it helps in the prognostication there, as if the patient have a very high level, then he's most likely of the 5% severe cases with the worst outcome. The third beneficial effect is in the epidemiology, because we can know through those tests the people who are immune, having the disease, whether documented or not documented, whether clinical or subclinical. Those patients with the positive antibodies to the test indicate that they had it at some stage, and they are at least for a few years immune against the disease. For all these reasons there, the FDA in the United States empirically count the serological testing as a part of the diagnostic tools of the disease. The drawback of the serological testing related to two facts. The first fact is that the development of antibodies, whether IgM or others, will lag compared with the onset of symptoms. They usually appear after the end of the first week. So there is at least a week between the appearance of the features of the disease, the clinical manifestation, and the appearance of antibodies. That's one. The second drawback is related to the time taken to get the result of the serological testing, which usually extended over more than a day. But there are some data coming from South Korea and China with a new generation of this test, which can present the result within 1 to 3 hours, which make it more easy to use. Culture. Do we use culture in cases like that? Is culturing the virus indicated? No. It is actually prohibited. It's avoided for safety purposes. Stool testing can reveal the virus, as we said, particularly in cases with diarrhea, and also cases toward the end of the recovery period and following the full recovery, as there are some data indicating that the virus can be isolated from the stool of the infected person even after the full recovery over the symptoms over a period which can extend around 3 weeks. But the clinical significance of the presence of the virus in the stool is not clear and usually is doubtful. What other tests we do? We talk about the PCR from the swab, we talk about serology, and we talk about the stool testing. There's no place to do a sputum testing in isolation, except if we are after getting more samples from lower respiratory tract. The routine blood tests are required for a variety of reasons. First of all, to assess the severity and also for prognostic purposes. These include the full blood count. It includes the renal function test, the liver function test, the coagulation study, the inflammatory markers, including CRP, ESR, and the ferritin as an acute phase reactant. These tests include also the creatinine phosphokinase, the CPK, and it includes the troponin, which is a cardiac enzyme. Now, the lab features which predict the worst outcomes are taken from those markers. and these include lymphopenia, so the presence of drop in the white cell count against the odds of usually having higher white cell count, particularly the lymphocyte, is one of those markers of poor prognosis. 2, a significant derangement in the liver function test and raised in the LDH. 3, acute kidney injury with a significant drop in the EGFR. 4, raised inflammatory markers all. 5, raised troponin. And 6, increase D-dimer. These, together with the prothrombin time, prolongation of prothrombin time, are markers of poor outcome or poor prognosis. Imaging. Imaging for chest X-ray, which is the simplest imaging we use in the diagnosis of diseases, is not substantiated. The chest X-ray can be normal in early cases or in mild cases throughout the illness, and it's estimated that about 20% of full-blown cases had almost normal chest X-ray or with minimal changes, like consolidation. So for imaging, the best modality is the CT scan of the chest. But this scanning is not a must for every single case of COVID-19, and it is reserved for hospitalized, unstable patients. The changes on the CT imaging includes consolidation as a typical features of pneumonia, or ground glass appearance with diffuse changes. But characteristically, the changes related to COVID-19 on a CT scan are mainly peripheral, and it involved both lungs.